Yes.
Hello and welcome back to our part two of the discussion. And thank you, Candice, for sharing continuously about your experience in long-term care in Ontario. In part one, we look on the history of how a pandemic started on March, and now we are focusing on the second part, what's happened on April 9th. And Candice will share with us the story of social work role officially from essential to
Yeah.
critical.
Well, thank you, Sasha, for inviting me to share again this process. It has definitely been an emotional time. It was actually took me a bit to go through my notes to be able to come back to this place to talk to all of you about it today. So we've been talking in the first part of this recording about gathering emails and connecting to people, loved ones that are outside of the home, trying to figure out how we were going to stay in connection with loved ones, and these that ended up being really, really crucial conversations. They were quite therapeutic at the time. I ended up basically counseling on the telephone for a lot of these conversations, but here we go into where that connection that social work was able to make was extremely crucial, and how we became critical workers is because we had these connections with every level going on, staff, and of course residents, loved ones, and community. So we ended up being the voice and the connection and the bridge in all of that. So that's where we left off. Was in this preparation, and it really is it an if or a when? I was sharing with Sasha before we started to record that this home is in a very rural area of Ontario. We were hearing of course, everyone by this point had heard of what was going on in New York, in definitely in Seattle, all the West Coast. And I know I'm talking to Sasha sitting on the West Coast, and you had all gone into things before us, and it was sort of coming across the country, not in the New York case, but in the Seattle and the Washington and Vancouver and all of that kind of thing. We were starting to have cases in our area, but like I said, I'm an hour away from our major city of Windsor, Ontario. And so that Windsor, if you look at Windsor and Essex County, I don't know how many people Windsor proper has, but it's over a couple 100,000. I think there's 400,000 in this area. And so we were looking at it as an urban area, and somehow in our minds, it seemed very far away. So it was if or when. And we really thought, okay, well, there's starting to be outbreaks. There's starting to be positive cases, and we're learning how to prepare. But we hope that we're preparing for something that we never actually experienced. So we thought that these cases might be isolated, they would stay far away, and that they wouldn't come to Leamington. So just before then, we'd heard rumors that at another congregate care facility that there may have been a positive case. It was never announced, but I remember emailing right to our administrator, Stacy, I think it's in Leamington. I think it might be when. And we started to think about this. So this is important to talk about in terms of finding the first case, because what we were told at that time is that it might be a when, but that you should make preparations. And it was this abstract thing. So everybody was like, okay, I'm going to make my own safety plan. Safety plan became two words that were going on at the time. And there was a lot of angst about it. We worked with people who were, better than 75 themselves on staff. And their families were begging them to not go to work. My family was as well. I'll get to that. But there was, we had a charge nurse whose spouse had a heart transplant. And, a lot of talk about we can't bring that type of virus into our homes, nor to our work. So we were making these safety plans. People had they were living with all kinds of people that had underlying conditions like diabetes and heart disease, like I mentioned, and other things. Some people were living with young children. Some people were living with older people in their homes. And so we were making these abstract plans. So I'm going to talk about arriving at work that day. And it was April 9th. That date is burned into my memory now, but it was just any other day. It was a sunny day. It was still cold here in Ontario. Like I said, I had quite a tremendous amount of resistance at home to me working. So I wasn't even allowed to bring my shoes inside of our home at that time. And I wasn't allowed to bring them in the garage either. So my shoes remained on the front porch throughout this entire time. So I can tell you that on that day that there had been snow, because every day I would leave our house and I would put my feet into these shoes to go to work, and my feet would freeze because there was snow in my shoes and I would wear them to work. So it was a sunny day and I arrive at work and with wet feet, and there are cars parked right out to the road, and we're on 5 acres. So this is really a lot of cars. And I thought, well, what could be going on? It had to be a huge staff meeting. I mean, I kind of knew in the pit of my stomach, I guess, somewhere, what must have happened, but there was no announcement. So people have to remember that we are listening. I was on afternoons listening to Ontario government's press conference between 1 and 2 on my commute every day. And very often, it became part of my job. Very often I would walk into our building and make an announcement about what the Ford government was telling long-term care to do. And they had not received the news yet. So on a policy level, I had not heard anything on the radio yet, but the cars were parked all the way out to the road. So I walked into the building and something was different. And what it was is that the day shift had received news. And afternoons was coming in, and the day shift would not go home. They wouldn't go home. Because all of a sudden they're telling us that the safety plan has to go into place. They announced that there had been a positive case in the home and that it was a resident. And we knew that residents had not received any visitors or anything like that. So we didn't know how widespread it was. We didn't know what kind of contact anybody had come into. And it was panic. So what I had done as a social worker is I had created just some sheets of paper, not anything that any of you may not have read. I mean, just what to have in your home, like dried, pasta and beans and legumes and wipes, which we couldn't get. And there were all of these Health Canada things that you were supposed to have in your home. So there was a safety plan. There were helplines. There were helplines for children. I had printed those types of things out. There were the most probably important piece, which is down at the bottom of this slide, is sorry. I am working from home right now, so there's some noise going on upstairs. But the most important part of this was actually from the CDC in terms of psychologically and emotionally how to enact a safety plan. There's an important part to this, which was that your mind goes into panic and you freeze. And so everything that you've been drilled, everything that you have been kind of rehearsing needs to come out. And if you've got some loose ends, that's a really difficult time to have those because you can't think through, you're panicking. You've got a positive case again. Testing was not happening everywhere. So you didn't know, testing was not even happening everywhere in our building. So you didn't know how this was going to spread or what was going to happen. And so your mind was filled with that kind of thing, not necessarily if you had dried pasta in your house. So I had ran off these packages. They were important things. I'd put them in the center of the staff room table, and everybody took them because you wanted something to hold on to. You wanted to check, I had a pasta in the house, or there was information on groceries that I had put together on click and collect. Never mind that these things were 2 weeks behind at this point. And so they weren't kind of almost not accessible, but people needed to have this information. So, but a lot of these safety plans went sideways. in this moment. And I'll tell you about a couple, which was that the people had owned campers in campgrounds. And so they had decided that if there was a positive case in the home, that they would go to these campgrounds. And that's how they would not go home. They would not go home to that loved one that had the underlying health condition. They would go straight there. They'd stocked it up with the toilet paper that nobody could get. I mean, or they thought that they had, in the fall before. And what we found out is that these parks were closed, which was another piece of legislation that was running simultaneous, and that we could not access. So the safety plan kind of went out the window for a lot of these people. So alternately, we'd been hearing on the radio and in the news that hotels who didn't have any travelers were offering free rooms for healthcare workers. And so we thought, well, we won't go home. We'll go to this hotel and so what I ended up doing as a social worker is taking my cell phone into the staff room, which Sasha knows me, I hardly even use my cell phone. But it became my tool in that staff room. And so I was calling these hotels and saying, we can't get into campgrounds. The administrator had made room on her floor and it had sleeping bags. So there were some people that were going to try to sleep in the administrator's office. We couldn't sleep in with the residents. That was an idea that happened worldwide, actually. Some people stayed locked into residences worldwide. Didn't hear a lot about that in Canada. I think one in Quebec. But that was kind of a difficult proposition because we had all these residents in the rooms, and there's always more, a lot of people don't realize there's always more staff in a long-term care home than there are residents. So some of the long-term care homes that I had worked in had 400 staff, even if they had 200 residents. So where were these staff going to go? And how are you going to get supplies in? And how are you going to care for if you had these young children? So an automatic answer that I saw in a lot of press is, why don't they just lock the long-term care workers in? And that was something that we had thought of, but it wasn't feasible and it wasn't long-term. And if you look worldwide, these arrangements did last for a time and they kept people safe, but they weren't a long-term solution. I don't think there's one going anywhere today. So in terms of these safety plans, so we called the hotels. The hotel said, oh, those rooms are for healthcare workers. And we were like, 75% of the beds in our healthcare system in Ontario are in long-term care. We are part of the health system. And they were telling us, no, these rooms are for hospital workers and for even EMS and stuff like that, but they're not for you. And they said they could give us a discount rate. They were going to give us $10 off if they talked to the administrator. So I had my cell phone to talk to the administrator. So we secured some rooms for like $89 a night, which again is not a long range plan. And where are you going to do laundry? And how are you going to eat? Remember that we are coming into our homes now and stripping down and putting our clothes right into laundry, and then taking a shower, like trying to rub, this virus off of us. So there's a whole lot of steps going on here, and we didn't know how we were going to do this and never go home. So on this day, lots of people had things in the back of their car for that safety plan that we hoped would never happen. But so anyway, Some of these workers were able to take their toiletries and things and go to a hotel room, and they just said, that's it, we are going to suck it up and we're going to pay whatever we have to on our credit card. Maybe it's more than we're even making, but it was amazing, the dedication, because they wanted to keep serving, but they didn't want to bring the virus home. So in terms of the campgrounds, I was on the phone talking to our MP. It was the day before MPP. It was the day before Easter. So I was amazed that they were actually very responsive, but there was nothing that they could do immediately for us. So a lot of us, so we were on the cell phone, some people had started to talk about donating RVs for healthcare. That wasn't big in popularity right on April 9th, but that became kind of an avenue that people were going to explore. But Sasha, you have to remember that we were talking about, we're done work, we have a positive case, we don't know where it is at this point, and we can't go home right now. So, and we didn't know if this day was ever going to come. So it's not like you could, yeah, no, but you couldn't book a hotel room for April 9th, because as far as we were concerned,
it will not happen.
It will not happen. So in hindsight, people will say, well, why didn't you? We didn't know. And we didn't know that.
No other preparation plans done in the past. So meaning there was no way of thinking what we do while we know it might happen, but there was no mechanisms in place. Like if you know the fire drill, you know what to do. There is step A, B, C, D. When it's pandemic, positive case, B, we don't know. And that's something which is important to realize, that we as are not prepared in a way how we should be, because we never have prior experience to that level that we need to do at pandemic. And that's why even social work in times of crisis and in times of emergency is critical, because what you were sharing, all of those supports which we start thinking, assessing situation in crisis, needed to be done right at that time.
Right at that time, because people couldn't, like I said, go home. Other people, I have to tell you that this happens. So panic sets in, and you always think, what are you going to do? So part of all my notes, and if I look at my personal diary, I had to have some explicit talks with people, some of them with administration in our building, but sometimes they were at home. And so you never really know what you're going to do. But I had to have explicit talks that I think social workers did have throughout this time, which you never in your lifetime could have anticipated having, which was that at the time, my children were 21 and 16. And so I have a whole section making the decision to keep working, because my husband said, I don't care what we have to do, we're going to take out another mortgage on the house. You have to stop now. And then every time I'd answer, but who's going to care for people? Who's going to be there? I'm the only social worker. He'd say, mark it on my tombstone. Mark it on my tombstone. And so it isn't until this moment happens that you start to see whether you're going to run into the fire. This is your own personal fire. And so I had to very explicitly explain that my children, they're not done growing, they're not done needing me yet, but they probably could survive, because and I had other social workers that I was working with telling me they didn't think it was an if or when that we were going to get COVID-19. It was, in some people's opinion, it was not an if, it was when you get COVID-19, what's going to happen. So we had to make very explicit choices ahead of time as to whether we were going to keep working, whether our families could keep going without us, and where we stood. Some people, these were abstract thoughts. And when a positive case was in the home, these thoughts became very real, and many people walked off the job. They, you know, and the phone, I get that'll be on the next slide, but the phone wouldn't stop ringing. And I'd say 75% of the people that were calling were staff, and they were saying $22 an hour, $220 an hour. I don't care. There's no amount of money that can, you know, that you can pay me for me to come into that building now. That the positive. So there was a lot of talk about what we would do, a lot of thinking about what we would do, and then there was the moment. I am not blaming anyone, because these people had very, very real things going on, and social work had a role to play in helping them to determine what they could do in terms of risk. I'm not talking just risk aversion. I'm talking very real risk to people in their homes, in their lives, that would not survive without them. And so they were not able to have the answers that I did, which is that I thought that, you know, I had a spouse, I had a partner who was working. We had a home. Yeah, we haven't paid off the mortgage, but we had a mortgage. You know, we had, I have older kids who are not babies. We have, you know, like everyone in life, we have this whole secondary condition. Who doesn't have a secondary condition? I mean, we're human beings, right? So there's things going on, but not to the seriousness that that some people were being faced with. So these were very real things. But the question remained, who is going to care for the residents? If everybody, because everybody has something going on. And fear was not one of them. So this was something important to bring up too. So many people say, well, why didn't you just quit? Or you could just collect CERB or anything like that. No, if you were given, the legislation was that if you were given enough proper PPE, which could be just a mask, and like I said, I've mentioned to you before, our shields were donated by the Mennonite Church, so we happen to have that. If you were given that, if you did not go to work, it was considered a refusal to work, which is a labor term. So you were not eligible. It's the same as refusal to work is the same as being, you know, fired or quitting, is really quitting. So you, just like you're not eligible for EI, you weren't eligible for support. And that's for a lot of people why they had to, even though they really felt like they couldn't, why they kept working in these vulnerable sectors was because, you know, I was very lucky that I had even a choice, because there were many people who did not have a choice and they had to continue working because they couldn't say no. But so that became really important with social work. I had to learn what was going on. The Canada Emergency Response Benefit, the CERB, came out somewhere around this time. And so, which was great in the sense that there was a safety net. But I had to know legislation. I had to know what the company policies were that were in place. Unfortunately, I had to tell people that fear was not enough to stay home, because that was a very big thing. People were panicking. I had to know how you could get online groceries, even though myself, I had never gotten online groceries. So I had to, you know, all of these things. I had to know what the rules were for children. There were, you know, daycares, of course, closed down. So how were people going to have daycares? They did open up healthcare worker. And again, we're battling the same. Are we a healthcare worker? They realized that we were. So how do we get our healthcare workers' children cared for during those shifts where they cannot refuse to go to work? So there were endless policies going on, as I said here. So I had these packages. Our company came forth and said social work services are going to be provided to staff. I had been leaving them bulletins on our point click care saying what I really feel, which is that they are heroes and I am here for them. And if you ever need to talk to me, it doesn't have to be official. I don't have to take case notes. That was very important. But I wasn't a referral from a doctor. I was not somebody off site. Some of these programs required a referral. Sometimes they took weeks to respond. I don't know of many staff members that availed themselves of these other programs that took so much, because the short answers, the ones that they wanted to get to, were on the fly. They wanted to pull you into an alcove or catch you in the dining area, or sometimes we go into the nursing office and close the door. There were a lot of panic moments that we just needed to work through. I did not take case notes. And they knew that. And so there was no, so they were able to be vulnerable and to continue working. And that became a company policy. In fact, it was on every bit of communication was go see the social worker, go see the social worker. I go back to part one though, that I'm only one.
There's
So
one social worker.
yeah. So now there's residents, families, and loved ones, communities. And because that can be, that's all the people that can't come anymore.
Ringing.
Yeah. Yes. And it's now staff. And at a certain point, it became staff and family. And I was just like, yeah, well. And so I took a list of private practitioners, social workers in our community that were accepting people at the time, not in person, but over the phone and through video. And so I was able to run off a number of those leaflets so that people had numbers to call, people to call for family. But I was there for them, and that became very difficult because family needed support as well, of family of the staff. So family of or loved ones of residents needed support also, and I was there to respond to them if they needed support regarding their loved one being in long-term care. And then I could make referrals beyond that to other people. So anyway, social work role pivoted big time to supporting staff. But I say pivot because you were always, I mean, that's why you're still there. I mean, the residents and the families and loved ones and everyone are still there, but you're there for the staff too. And now your shoulders, my shoulders have always been broad. I've always seen people one off from staff. That's always been there in the background, but now it's everybody all the time. So, and now I'm in the staff room, and that's that pivot. So I stayed there for most of the day until we got it ironed out that these people were going to a hotel room. The camper thing didn't get worked out on the first day, but we were connected, and other arrangements. People took people into apartments. I don't think anybody actually slept on Stacy's floor, but that was in the mix. And so then I went back to the nursing office, and that's the next slide. Actually, there's one more point on this slide that I want to cover. So how did we discover the first positive case at the home? I want to make this point. So the focus early on was the hospitals. That was on the national news. That was, is our healthcare system going to be able to support the number of people that we expect with COVID-19 to come to our hospitals? And is our healthcare system going to be, will there be enough ventilators, all of that kind of thing? So our home used to have a transitional care program where a number of people who were coming from rehabilitation from the hospital, but they weren't quite ready to go home, would stay with us for 90 days. Social work was big time funded through this transitional program because they put all the resources together. So I would say to those transitional residents that they were in a boot camp. And they're going to have physio, and they're going to have occupational, they're going to have social work, and they're going to have pharmacy, diet, and things that residents get, you know, routinely, but it's going to be intense. So that's how we got there in the very first place, was this transitional care program. But what happened here is prior to April 9th, the hospitals were having people leave their own like surgery, rehabilitation, recuperation, things like that. They're having them basically decant, get out of the hospital, And where were they going to go? So they came to long-term care programs. All the long-term care homes that house these programs were told immediately to let their people, those 90-day transitional people, go home. So part of my email calls and all that kind of stuff, I would run into these transitional families that were saying, I don't want Bob to come home. He's not even ready to walk yet. How can he be coming home? But we were freeing up the beds. So at this point, if a bed, I remember saying to my family, if a bed is open at 10 a.m., I'm feeling overwhelmed with the new people coming in because it's full by 2. So, so immediately we're filling up with these hospital patients. And so the reason I bring this up is because that's how we started thinking about this at all.
Connection.
We assumed that these people had been tested at the hospital and that they must have a negative to come, negative test to come into a long-term care home. And then we found out, no, there was no time at this time to wait for results. So we were filling up with these people between 10 and 2
Yes.
who didn't have results. We didn't know if they were COVID positive. So then it became that they needed to be tested in the first 2 weeks of being in their long-term care home. So again, they're not really looking at long-term care. They're looking at the hospital system. How are we going to open up this? But they're sending people into long-term care homes to capacity. So, but they said that's okay because they are isolated. And in fact, they were isolated. Okay. But they had tests done. So during this testing process of the people that were coming from hospital, we also, if residents who were in like adjacent rooms had any what we would call respiratory symptoms, so coughing and all of the things that are on the COVID screening sheet, they would test them too. And those are the only tests that were going on. So how this first positive case came to be is that these test results came back. And what threw everybody and what caused a lot of the panic is that none of the hospital admissions actually tested positive. Who did was a resident who would never have been tested, in just one, who had not had any visitors in an adjacent room. So and she hadn't had visitors for years. So it wasn't like some carry-on long haul thing.
Right.
And we couldn't figure out how. So, okay, so this is going on. The telephone will not stop ringing. Like I said, lots of these people are staff members that are calling in. They're never coming back, they say. Also, the families are calling in. It is now hit the news. So where I didn't hear it going in, it's all on the news, on the half hour, on the hour, right? Public health is calling and talking to administration, and I am through a wall. I can hear them because I'm talking to families. I'm talking to loved ones. And they're all very, very concerned at this. Well, for the most part, some of the, yeah. So social work is just continuously pivoting between staff and loved ones and residents. And now we're into loved ones, okay, here. So they want to know why and how. And at the same time, public health is saying, who has had contact with this resident who we didn't even expect. So we've got to put those people on a list and we've got to test them. Yes. How did social work become critical? It became, and we're shrinking again. We didn't even think we could shrink, but we shrank again in terms of staff. So we went down to one meal choice so we could cut dietary. So one meal choice is an oxymoron. There's no choice, you get one meal. And one bath. So no bath team. And we've already, other professionals, if they haven't gone, they went on that day, or they're gone. And we weren't already by company policy, didn't become provincial till April 22nd. But by company policy, we already could not work at more than one home. So we lost a number of workers that way. because they had chosen to work at a different place. So the telephone won't stop ringing. Public health is going on. They're saying who's had contact with this resident. By this point, we'd moved to the critical list, and I had been someone who I had held hands. I was not a PSW. I did not do full intimate care work with the person, but I definitely wanted to know, like the part one, how was she going through depression at this time? And you don't know who is going to be, you had no idea. So
you connect.
So I was one of the 50 people that were tested. The staff was looking for N95 masks at that time. We had N95 for people who were isolated in those rooms. So that's what happened, is that if you had a positive case, they were isolated to that room. They could not, I mean, all the residents were in the rooms, but these people, the people who had tested positive could not for any reason come in contact with anybody else. And so that's where you start seeing on the news images of PSWs and pretty much hazmat suits, gowns, and all that kind of thing, gloves and shields and everything, caps and everything, masks, going into these rooms. So, but those folks got N95 masks. The rest of the staff, there wasn't enough supply in Canada for everyone to have an N95 mask. And that becomes important as we go on. So they had 50 tests. So as I've already explained, there were 170 workers, there were 120 residents. So who gets those 50 tests? So I ended up being one of the first people. So on April 9th, in the middle of all this, it was 10 o'clock at night, we received these swabs. And I think I was the second person in our facility, staff-wise, to be tested. And I actually wanted to go because I knew that the nurses that were being charged, remember, nobody can come in, were being charged with this, are now doing something that you don't go to school to train to do corona swabs. Yeah. So I thought, well, I might as well be me. So, I mean, if, in terms of getting better, and they were excellent. I don't know. It was like they trained all their lives to do this. So, but we couldn't figure out why 50. So I'm emailing, because I happen to be in school, my social work epidemiology, person who had studied epidemiology, professor, poor person, because he's like, there's too many variables. I don't know what to tell you, but I'm like, is the number 50 statistically significant? Because I remember you saying that. And so I'm thinking maybe we only got 50 tests, because that really will, give us a probability. And he's responding, Candace, thank you for your service, but I can't tell you, I'm not, I'm not on the case. But it was very kind of him to even entertain this dialogue with me. But I was sure there had to be a reason for the 50. And to this day, I don't totally understand, except that there weren't enough tests going on at this time. So, oh, okay, I should come back. So the testing, so I wanted to go there. So they were testing those who were in immediate contact. We did know that this person could not be case 1. We knew it had to come from somewhere. And we knew that the public was largely untested. So you're watching the national news and you're saying long-term care is this really bad place. It's like we manufactured coronavirus. And so you almost wanted to scream, no, our residents are the ones who suffer the most devastating consequences of this virus, but they are not manufacturing this virus. They are the only ones that maybe are being tested, and that's because people are dying, in long-term care homes. But by and large, the people shopping at the big box stores that stayed open, those people were not tested. And I can tell you straight up that no long-term care worker, social worker, otherwise, was going out on a limb in any way during this time. We were not, like, in Sasha's class, I talked about how I wouldn't stop for gas. I used to once a week, no matter if I needed it or not, I would top off my gas tank. Well, maybe more frequently than once a week, but I never let it go really. My grandfather always told me never let it go underneath half. And so after missteps as a young person, I learned that, but I changed all of my habits. And so I started grocery shopping at the gas station, because that's what happened is I would let it go all the way to empty. And that was the one place that I had to stop. And I think most long-term care workers were like this. We knew that if this virus was going to come in, that it had to be from us, because everything else was closed off. And so like, my kids still tease me about the dinner offerings from the gas station, because it was like, ooh, would you love a lovely red or blue Gatorade with that, sir? Because that's all that we had. Yeah, we wouldn't take a risk at all. And we were wearing gloves. I had gloves from my son's girlfriend, left them in the back of my car because she was training to be a PSW, so I happened to have them. But we were only using them one time. We knew how to use some PPE, but the public did not, for the most part. We had people wearing gloves that were like picking up things and putting them down all around. These variables were limited in April, because although people were still in these big box stores and things like that, there were less people on the road, obviously less people working. So there were less variables out there, but it was still a very clear and ever-present danger that we were going to pick something up, doing something so outrageous as getting groceries for your family, right? And in my case, getting gas for the car. That was the thing I couldn't avoid. And so we knew that this person could not be case one. We knew case one was out there, that there were more, and we didn't know if it was spreading within our home. We didn't know what we could be bringing in on any given day. But we were mainly staying to ourselves, and we would talk about it while socially distancing, because now in the staff room, you can't even speak, speak to someone. By this time, we were signing in. When our first positive case happened, we started being screened twice a day. So we were screened at the beginning of our shifts, and we were screened at the end of our shifts, and we still are to this day. Residents became tested and screened 3 times a day. So every single shift, days, afternoons, and nights, screens residents for coronavirus 3 times a day, every day since that day till now, right now. So it's difficult. I get a lot of referrals about not sleeping because somebody's coming and pointing an infrared thermometer at your head in the middle of the night all the time. So so we have these 50 tests, and so we realized that it wasn't enough. But we didn't know how to get more tests in. And so EMS, the hospitals through EMS, had coordinated an effort to go to all the long-term care homes, because we were all starting to have outbreaks. Some were having really devastating effects going on all around us. We were sort of holding our breath and waiting to see what the effects were going to be in our home. And they sent out EMS. So the EMS came and tested every single resident and tested every staff. So this was just prior to April 24th. The reactions were, it was a very, very difficult thing. That's another pivot as a social worker. So when EMS comes in and starts testing people who, for the most part, have dementia, there were people, one of the residents, literally her knees were buckling, and she was calling for her late husband, Tommy, and she's going to the ground, there's a man on me, because many people did not have any understanding what was going on, but we needed to have this testing, and it was mass. So we have a little bit of an idea of what's to come with the military and what they might be seeing, because we realized that the residents were not understanding what was going on, and they didn't understand why these people were in the home and doing somewhat of quite an invasive test,
Great. And I think that's something which we when we cover the first case. I know we will have 3 more minutes just to summarize that
Oh my
piece
goodness
of
gracious.
part. I
Okay.
know it's a hard one, but it's the first case. What do you think? What were that role of social worker? What make it critical
Okay,
for?
what made it critical is that we were in the middle of everything. We were addressing everything at every level. So we had, you know, families, loved ones, very, very worried. We had residents that were reacting to being tested. We weren't even allowed to tell them who the positive case was. All they know is that security went from being high to extreme. So we were running between all of these things, and now we are by policy going to be the social worker to any staff anytime that they were needed. And so there was never a time that social workers were not needed. We are also by province, we were redeployed within the home, which means that we could forgo a lot of the union rules, and we could be called to do anything at any time, which I said in part one, I did, and we were. Obviously I was a little busy with these other things going on, so wasn't totally available to do anything, but I was ready to do so. And I was wearing scrubs by this point so that I could be asked to do anything at any time. And so it was social work. It was on the list. Like I said, we went down to no bath team, no meals, etc. And so social work was put on that critical list that remains. So the list went from here to here and then to here. And so essential workers were no longer who could come into a long-term care home. You had to be considered a critical worker, that your work means life or death to people, to residents. And so we became part of that critical list, that very short list of people that could come in, because our work at this point was considered critical to keep people, and it was. So yeah, fear and apprehension. I can go through all of this. That the
We
home.
will do in part 3, but definitely, because I think what it's very important when we now call critical, we also need to have that education and what makes us critical and supports, because it's a very high responsibility to be thinking about life and death, and how much it's important to recognize that this role is critical mostly every day, but it's only become recognized particularly critical in times of pandemic, because in this case, we as social workers, we need to be there not only for residents and their families, but also for staff and their families. That's
So
what
that
the
they can
challenge.
keep doing, yeah, so
Yeah,
that they can keep doing the things that they needed to do,
yep,
which were definitely life and death, you know, biologically. Yeah, yeah.
that's a huge one. I know we'll come back in
Wait, we
this.
need to be in here. I want to conclude with one thing
Yes.
though, which is I do want to include with the quotes. I want to say that this is a very serious matter. As of June 12th, when I gave the lecture the first time, there were 2,498 deaths in long-term care alone. That was a huge, I think it actually changed that day that the 8th long-term care worker had died from contracting COVID-19 at work. So these were very real dangers that were going on, and those numbers have risen, but these strategies have worked. And to be honest, we did flatten the curve within long-term care that we'll get to is changing in subsequent parts. I want to recognize the role of the residents here in conjunction with social work. They were basically counseling us in many ways. Sasha, I'm sorry, I'm going over the time, but I want to get these quotes in. So the first one was from a resident who was turning 100, and she was amazing because she'd been through so many things, as you can imagine. She talked about growing up with flu orphans. So from the Spanish flu, the flu of 1918, 1920, and the people that had died during that time. She'd grown up with these flu orphans, had father in World War I, gone through World War II, all of this. And she said to me, she looked like old Rose from the Titanic. So to get a visual, and she said, people are going to criticize. Hindsight is 2020. It's going to happen. I've seen it through history. They're going to look back and they're going to be able to criticize. You don't have that luxury. She said, right now, you do not have the luxury of hindsight and critical thinking. You have to do what you think in your heart is the right thing. It'll never be wrong if you just go with the best intentions. And that person just passed away very recently. It was like she saw us through the pandemic, the first wave, and all the way through she would see me doing things as a social worker and engaging with people and things, and it was like she was approving all the way through. She had so much advice about staying informed, and just she really got us through this time. One person said that she was worried, but she said, we have been through so much before. And this person had been through so many life events that I could go on about. But she wanted us to know that we were going to get through this too. So they're telling staff, let them know that we're going to get through this too. Look at all the things that we've been through before. This is another time. This is just another period. And I love I love all the residents, but this particular one had fled Germany, this last one, in World War II. He fled the Nazis, and he'd been all over the world using his skills, very critical thinking skills as an engineer and all this kind of stuff. And he had led people. And he said, he looked at me and he just said, whatever you do, don't panic. And he said, because if you panic, you're going to make mistakes. And the way he said it, I know this. And, and he said, my best advice, I've got 3 things. He said, take walks. He said, drink cranberry juice and use Dr. Hose. And I told Sasha before, at that point, he zapped me with the Dr. Hose. I was like, ah. But these were really, really practical things of someone who had been through, World War II with 20 sacks of potatoes, and then they sent the potato bug in, and starving to death, and just all of these huge monumental things throughout life, actually, around the world. And the number one thing is he was literally looking at me and saying, breathe, don't panic. You're going to make mistakes if you panic. Just do these things, bring it back to the present. And these are the things you do. Keep yourself healthy. There was a Buddha quote that I kept looking for here, that I kept using there. And it said, stop trying to calm the storm. Calm yourself. The storm will pass. And that is essentially what this resident was saying. So yeah, anyway, thank you very much, Sasha. I'm sure you want to continue with the summary, but I wanted to get to these very important resident quotes, because these were voices going on throughout that were counseling us.
Right, and we will hear these voices because it's a summary only of part 2. It's a summary of the first case, and we have hope. And those quotes allow us to see that the process still continues. And we're documenting this process by having those interviews. And I'm grateful, Candace, for sharing that story. We will now build from what's happened from April 9th until June, when we have our first meeting of that discussion in terms of how that critical work uncover. And definitely there is much more, because we are already in October, to see what's happened and what we need to learn to make sure that we can support people to the best as we can as a critical social workers, in a way that we provide critical service in times of need, in times of life and death, in times of having those skills which are essential and critical for persons being supported in every day, at every time, and every crisis.
Yeah.
Thank you.
Yeah, thank you. Thank you. So if you're a social worker out there, we do make a difference. We do. And I hope telling the story reaffirms what we know, which is we make a difference every day. And we did here too.
Great. Thank you, Candace.
Thank you.